There's an old model, time sort of immaterial. It's been there the whole way, and I think it's pretty reliable in predicting what people want and expect from their health service. And there's a bit of a hierarchy. It varies from country to country a little bit in the order of the 4 A's I'm going to talk about. But I think these are going to be the fundamentals that will not change. And whatever technological advances, whatever services sort of address these patient needs, there's four key things that patients look for. And I think those are not going to change. They're going to stay exactly the same.
Welcome back to the Scale My Clinic podcast. Today I've got my good buddy and partner in crime, Sachin Patel. Welcome, Sachin.
Morning.
And what we're talking about today, Sachin, is we are talking about what remains the same. Now, a lot of what we talk about is what are the changes that people need to be aware of in advance and what do they need to be thinking about, what actions they need to take prior to the change coming into play. But the thing we often forget about is it may be more important to think about what's going to stay the same, because most of your planning is going to be around what is staying the same. So I've picked a decade because I figure if you can plan over 10 years and you can hang your hat on the things that are remaining the same, then that's probably going to be useful for everybody. So that's what we're working on today, Sachin. Now, I know you've got some tradespeople at your house, and for those who want to guess which room Sachin is having worked on, you can put that in the notes below wherever you're seeing this. All right, Sachin, over to you. What do you think is going to remain the same in the next decade?
So when I think of this, I think the fundamentals are the same. And so if we think of the stakeholders when we're talking about this, then really we're talking about examining this from patient side, GP side, practice side, and then the wider system. And so if we think of it like that, maybe work through each of those stakeholders. Wanky word day. So let's start with patients.
I thought you were going to become a not-for-profit then, the way you started talking. Just checking you got the right hat on.
I don't know.
Patients.
So patients. There's an old model, time sort of immaterial. It's been there the whole way, and I think it's pretty reliable in predicting what people want and expect from their health service. And there's a bit of a hierarchy. It varies from country to country a little bit in the order of the 4 A's I'm going to talk about. But I think these are going to be the fundamentals that will not change. And whatever technological advances, and there's been a lot of a case made for both technological advances and for sort of widespread care where general practice has sort of been fragmented to other services. Whatever services sort of address these patient needs, there's four key things that patients look for, and I think those are not going to stay, not going to change. They're going to stay exactly the same. So generally, the order is affability, then accessibility, affordability, and ability of the practitioner. And strangely, ability quite often comes at the lower half of those four when patient preferences are surveyed. And so I think those, from a patient perspective, are still going to be what people look for. They're going to look for affability. So that means they're going to want a service that is easy to deal with, people that are easy to deal with, and that they find a connection or rapport with. And so whether that's done digitally or physically, that skill is going to have to remain in the service provision side. So that's affability. Then when we come to accessibility, I think we're seeing, all of us have been trained now to get things at a touch of a button. If I want to watch something, I can just smash through every episode of a show. And so I've been trained by technological advances to want instant accessibility. And so we're going to have to think about how we maintain accessibility, because the patient wishes and wants for that are going to remain. And it's harder for us nowadays to wait with uncertainty as a general rule as a population. And so accessibility is going to be super important and is going to remain a key issue. Then if we think about affordability, there are people who make decisions on price, there are people who make decisions on value, and then there's a group in between, but broadly two groups. And so the price conscious, which is being, we've already got a roadmap from the Australian government that over the next 4.5 years, they see affordability from their perspective, meaning getting to 90% bulk billing rates by 2030. But that doesn't tell the whole story. There's a whole group of the population who are more than happy to invest in their healthcare, and we're seeing that play out now as these high-end services that are rolling out in terms of value. People's perceived value of those is huge. So high-end services, I mean longevity clinics. You've got more subspecialized sort of cosmetic, aesthetic services. And now you're getting sort of preventative health services, which are, whole body MRI, $3,000 to $4,000 a year, and people are willing to invest in that. And so what that tells you is there is a substantial group of the population that are willing to make that investment in their healthcare, and they see the value in that. And so that trend of price versus value is there's always going to be a trade-off. And so when we are thinking of service provision, we need to think of which of those groups are we specifically working for.
So that's about just understanding your avatars, right? Like who am I serving? What are their expectations? Price is what you pay, value is what you get, what is value for that group of people. And so that's important for anybody running a business to be really clear on, because if you're not getting that right now, you might not be here in 10 years anyway.
Absolutely. And then, the basics of healthcare is you want the professional that you've seen to be able, but strangely, ability comes normally at the bottom of that list. And the reason for that is because it's a given. If you've got a qualification or you purport to be a medical practice, people just assume you're able. Like they don't think, oh, I wonder if they'll be able. They're thinking, am I going to like the person? Am I going to be able to get an appointment when I need an appointment, or service when I need a service? Is it going to be good value for money, or does it fit my budget? And then, oh, did they know what they were doing? Of course they knew what they're doing. Oh, they didn't. Oh, now let me worry. So ability often will come towards the bottom of that list. Strangely, all of these technological advances seem to focus on ability, when actually, when you look at the hierarchy, it's often at the lower end. And so with the rise of AI, it's often about, AI diagnosis, AI treatment. Well, if it doesn't solve the other three, and I don't think it has solved the other three at all, then it's a moot point at the moment. And so you're going to have humans powered by AI, not tech just doing all of the jobs for the patient, I would say.
Not AI powered by humans.
No.
Now, Sachin, I had two interesting ability stories to share. One was from a surgeon who said to me that the dressing, the attention given to the dressing after the surgery was not the most important part of the surgery, but a super important part of the surgery. And their reason for this was that the patient's not going to see anything I did on the inside. The only thing they get to see is the dressing. And so if that doesn't look meticulous, then they're going to assume the things underneath the dressing also aren't meticulous. So just, there is some element of branding that goes with this, and just attention to detail. And one that I have that's a story of how not to do it, and how when ability is questioned, all of the rest of it falls away. So this was an example of a family member that went to an orthopedic surgeon that was a foot specialist. And as part of, the illustrious group that they went to, after the first consult, he was sent off to the podiatrist, ended up getting a whole bunch of inserts and so forth in the shoe, came back to see the orthopedic surgeon a short while later and said, oh, let's have a look at your foot. As he took his foot out of the shoe, he noticed all of the podiatry stuff in there. And the surgeon said, who put all that shit in your shoe? and so this person was very expensive, well beyond reassuringly expensive. And you can imagine that this person, the patient, thought, what the hell? Like, you've just referred me to this person I've paid all this money, and you obviously don't read your notes, don't know who I am, and don't have any connection to the reality of this was all initiated and instigated on your recommendation. And so, their trust in the ability of that surgeon collapsed in that moment. So it is super important to make sure that we don't make those kind of mistakes.
Absolutely. I think I've told you this before. When I used to see newborns or babies or children, and you're going to put them on the examination couch, new bluey or whatever you're putting on your couch, and then it's like you've scrubbed for theatre, because of course you want to have clean hands to handle the baby, but part of it is also showing the parents that you're about to manage the most precious thing in their lives and handle the most precious being in their lives, and you want to give them confidence in your ability. And so it's exactly the same. And so some people do that consciously, some people do it unconsciously, and some don't do it. And it really is obvious to the patient. And you might be the best clinician in the world, but it's obvious to the patient from their perspective that, I can't trust this person. So that's the patient side. You got anything to add for that?
I think, with the 4As, it just comes back to ultimately the therapeutic relationship is about trust and respect. And so the value of somebody who knows you longitudinally, we know longitudinal healthcare is important. And I think when you're having task-based substitution, which is massively popular with health economists and politicians, because what they think is, well, anybody can do a blood pressure, so the person who's on the lowest hourly rate should do the blood pressure or give a vaccination or whatever it might be, because they don't see the things that wrap around the activity, that you don't just do a blood pressure, you're eyeballing the patient and you're talking to them about what's going on with their life otherwise. So the fact that there is a lot of fragmentation of health services and disintermediation, just others cherry picking parts of the work, but not the whole work. And we're seeing this trend in the NHS, but a lot of non-doctors that want to become doctors, but strangely are not enthusiastic about doing the work of becoming the doctor. They would just like the shortcut to the titles and the accolades of that. And so I think, it's going to be really important that general practice talks about the value of longitudinal care and of coming in for the things that may seem incidental but are part of overall patient care. I think that's going to be really important, and that might be about the doorways, the access points in. You'll no doubt address that at the system level. But I think the fundamentals of longitudinal care, having somebody who knows you well, maybe they even know your family as well. It may be that you provide care for more than one person in that family. The things that GPs love are the things that patients love. I know that as a GP, I don't love seeing a lot of new people because I feel like I want to understand them, their healthcare, their aspirations and goals, and how they fit into the community and their family unit or whatever it might be that's appropriate for them. All of those pieces come together to help me think about that person, over time. It's hard to do that with a lot of new people or with really superficial understanding of people, because you have to make a lot of assumptions, and a lot of the time you'll be wrong with those assumptions. I remember somebody telling me that assume is composed of us, you, and me. You'll make an ass out of you and me if you assume. And so that longitudinal care is really important. I think there will be forces that seek to fragment and fracture that. And so we need to work against that to make sure that we hold people to longitudinal care, because there's benefits for us as practitioners, for the practice, and more importantly to the patient and the community, the people surrounding them. So that's probably the only other part of the patient side.
Cool. So then I think of the GP side. And so a little while ago, when I learned and trained to be a GP and we did consultation models, my favorite was ICE. I did not meth, not meth.
People wondered how you got the good marks and stayed up late, Sachin. Now they know. You're straight out on air.
The ideas, concerns, expectations. There are plenty of consultation models, but essentially those, again, have been around for a long, long time because they form the basis of high quality longitudinal care, as you just mentioned, and good relationships and rapport within a consultation. And so that fundamental is going to be there regardless. You're going to need to be able to elicit what is the patient thinking, what are they worried about, and what are they expecting to be done about it. Because that's going to be key in finding out and solving the clinical conundrum that they've presented with. And I think, strangely, those that are not in general practice don't comprehend this part. This is the bit that I think is linked closely to what you just talked about, which is knowing a patient well. People don't come in, however much the modern world wants us to have that, where they have a label stamped on their forehead, or pulmonary.
I'm here for my urinary tract infection.
Yeah.
Such.
Yeah, exactly. Now, there will be conditions where it is very obvious, barn door obvious, but in general practice, you're trained not to make an ass out of you and me. You're trained to go a bit deeper. And that's where being able to unpack what the person's presenting with, what they're presenting with in terms of what you can see, but also what you can't see. Because the reality is that GPs are highly trained in picking up those cues, both verbal and non-verbal, as well as the consultation is not just sitting in the chair at the desk. The consultation starts from the moment, depending on how you practice. My preference is always go to the waiting room, call the person, watch them walk, shake their hand, let them come in, sit down, because that's a massive part of information that you get about physical and psychological health straight away, because you can see their affect, you can see the way they come in, eye contact, all of that. And so that fundamental is not going to change. The need and the ability to be able to connect and draw a good history, and then form your hypothesis, and then do the tests and examinations required to confirm or deny or disprove your hypothesis. And so that isn't going to change.
In fact, Sachin, I think it will increase because there are more tech tools trying to replace. It's like you're trying to figure out a problem with one of the usual suspects, Qantas or Telstra or whatever, and you're going through all the palaver with the AI stuff and the chatbot, and you're trying to solve the problem. And you just think, look, this particular problem isn't accounted for in all of the options that are there. And then you finally get to speak to a human and you're like, oh, this is good. Now we might get something done. And so I think because universally there's kind of a movement to robots to solving problems, customer service is more robot based, there actually may well be an increased need for connection, just as the amount of remote work means there's an increase for connection in workplaces or more event type things, more socialization. We may see the opposite. It may be that people seek more of that connection and in-person understanding and appreciation because they probably don't get it elsewhere in life as well.
Absolutely. And so I think the need to be trained in that, whilst understanding, the wider new technology landscapes, there's going to be some changes with wearables and other remote monitoring technology and AI-driven algorithmic sort of alerts, etc. All of that is useful information, but it's supplementary information. Nothing really replaces the doctor-patient interaction and the consultation. And so it can be easy for this task-driven focus and sort of diagnostic label-driven focus to be the big push. Pharmacists are going to manage UTIs. Yeah, well, first you need to diagnose that it's a UTI. And diagnosis isn't a simple skill to acquire. There's a lot of training and information that comes behind it and practice. And whilst technological changes may enhance the ability and speed to which you get to a diagnosis, I don't think they replace the diagnostic process. And doctors are uniquely positioned, especially GPs, to do that differentiation. Take an undifferentiated presentation, or actually a differentiated presentation. Yeah, I've got a UTI. Oh, really? Well, you don't, as a doctor, you don't go, okay, here you go. As a GP, you say, okay, cool. And then you start from the beginning. Tell me what happened. How did it, you go through the whole history and then you examine. But in your head, which the people watching and the people who count the prescriptions at the end, they may just see the prescription. They don't see any of the unseen and unrecorded. The only time it's dealt with as if something went wrong and someone looks at your clinical notes. No one actually understands the whole thought process that's gone on, both the tangible and the seen, plus the unseen, which is experiential. And so I think that basic consultation model, being able to elicit, and I agree with you, as people become more connected digitally, less connected physically, you're going to have to improve the skills and maintain and improve the skills and the focus on that, being able to draw information, because you're often going to probably have people who've been through some AI diagnostic at home, or Google or ChatGPT or whatever AI model is running at that point, who come in convinced they've got this thing. And it doesn't mean we don't listen to them, but we have to zoom out from that and think wider, like we currently do. And their diagnosis that they've come with is a part of the bigger, they say they think they've got, is part of a bigger process that we would then undertake. And so I think those skills and the requirement for those skills are actually probably going to increase, because they're probably going to become more scarce. We've seen in the UK where they've tried to task substitute, that there's been a huge swathe of unintended consequences, resulting in the fact that much of this has been rolled back, and the BMA have actually gone on record now refusing to accept physicians associates, or whatever they're called. Not physicians assistants, that's different, but physicians associates, people who are standing instead of a GP, often without actually a patient understanding that they weren't seeing a doctor who's been trained for the best part of a decade or more than a decade. They're seeing someone who may have had a 1-year training course part-time, and there's been well documented sort of negative clinical outcomes that have sort of resulted from that. Not to say we're perfect as doctors, but we do run a thorough process that has been ingrained in us over a period of years, and we've been thoroughly tested and have to continually maintain professional development.
Yeah, I think Sachin, we did some work on this in terms of the volume of work. So again, if you were looking for a tradesperson or a craftsperson in any area and you wanted something done that was really particular, you'd look for volume of experience. Have they done this before? And when we did the work on this, it was between 12 and 15,000 hours of experience for a GP. And I think it was Malcolm Gladwell who, if he didn't coin the 10,000 hours, he certainly made it more popular in terms of the amount of time to become an expert. And that's more than a decade of work full time. And so to assume that somebody who's done probably less than 100 hours of work in something is able to offer an equivalent service is actually delusional, because people don't present, as you said, with a label on front and a nicely contained little box as to exactly what's going on, and they won't present with symptoms from outside of that. Isn't how life works. That isn't how humans work. And so, even people who've done a full course, and again, this is not to denigrate these professions, pharmacy, nursing, etc. They're all in the low thousands of hours to attain those skill sets, really important skill sets, but they aren't the skill sets of a doctor. And I don't see any doctors out there claiming that they are pharmacists or nurses or whatever other professions there may be. And so they're all really important professions, but they are different. And there is not a bridging course other than going and doing the actual course. I think that's the key thing. And that's really what is being shown up by this sort of really aggressive task substitution work that is going on, particularly in the NHS, and kind of really confusing titles and just a real muddying of the waters in terms of, who has what expertise. I don't think anybody is served well by that. I don't think the people doing the work are served well by it, because at some point in time, you're going to come unstuck. The problem is that Dunning-Kruger says that you're going to be most confident when you're least competent. And so you have a lot of overconfident people with low competency that they're running with scissors, basically, so that they're going to come adrift at some point in time. And then they're being misled by the messaging from the services and from politicians that there is equivalency, and that's just not true. So I think we all need to be aware of that sort of trend that's coming. It does seem to be a global trend, even though things are being wound off in the UK. And we're probably ahead of them. Australia still likes to enthusiastically embrace the offcasts of UK health system. In fact, we'll often import the people who created those problems, pay them well, and see what happens here. And guess what happens, Sachin?
Yeah, it's doesn't even bear thinking about. But like you said, right? If you do a prescribing course, then guess what your job is? Write prescriptions. I've done a prescribing course, so I can prescribe. So I must prescribe. Very different to a GP, whose job is to diagnose and then put together a treatment plan, which may or may not involve any medication. They're completely different, right? And so I think you just got to have confidence. I think that the role of a GP will be extremely difficult to replace, and so things that will stay the same. That was your question. Is those whatever format they take and whatever technology is there to enhance or enable some of that, the basic fundamental of a good consultation model and process, a diagnostic process, a treatment planning process, and communication, high quality communication to ensure that there's a shared understanding and concordance with the treatment plan. Those are the things that they'll be the same probably for forever.
Yeah, agree.
Next 10 years. Let's go to practice side. So obviously there's a lot of change afoot as we're talking around the technological side and political changes, etc., external changes. But from a practice side, if we think of the administrative side and then the nursing side that support the GPs to do their work, I think from an admin side, you're going to have still that need of affability. We talked about affability, accessibility, affordability, ability, the 4 A's. You're still going to need to have the personal touch. So that has to be the same, even more so, because as things get more digitized in service industry, the personal interactions are going to be even more valued by patient and by team. And so, again, the team are going to need to be prepped to continue to provide exceptional customer service, both to GPs and patients. And so those that can do that well will continue to outperform those that don't do that well.
So can we just pause on that a little bit and just talk a little bit more? So you're talking about in-clinic, well, this could be remote work as well, but the patient experience being the focus from the admin/reception team. What are the sort of things that are in your head with that, Sachin?
Yeah, so I think personalization is a big thing. If our mission in general practice is to provide the best ongoing care and do it in the way that evidence shows is best done, which is longitudinal care, long-term doctor-patient relationships, well, this is a facilitator of that. And so by personalization, it means if you're in person, taking the time to check on the patient, how are you, the basic interactions, but also pick up on any cues that may aid other people in the journey. And the best receptionists that I've seen and worked with, if they spot something, straight away they're a message, they're not themselves, or they'll bring it up somewhere. And so I think that part is going to be super important. Then there's going to be making sure that people have had the services that they should have had, because things are going to get more complicated as we go forward. The service offerings, the range of services that a general practice might do. And so as an administrator in that, that's going to take on, it's not as simple as just book an appointment, bill the person, or sign the form, off you go. It goes way beyond that. Then in terms of, so there's going to be more of a coordination role. I think, the practices that do well, that's just going to become more prominent beyond appointment, because the simple stuff like appointments, etc., will probably be gone to technological solutions. So it's the more complicated and nuanced stuff that the admin are going to be dealing with. And so that's going to be important both for patients to make sure they get what they need, but also to retain doctors, because if you're not providing high quality administrative support, then that's going to lead to frustration from a GP angle, because as time goes, we're mainly talking about what's staying the same, but there's going to be, we've already seen, rising complexity of care and conditions and comorbidities. And as that happens, there's more cognitive load on the GP. And so there's probably less tolerance for poor service from the administrative side. And so I think those are the things that we're going to have to be doubling down on to make sure that we're staying ahead.
So let's talk about that. So admin and reception looking after a GP. So what does that look like, and what will remain the same about sort of excellence, high performing clinics?
So from the things I've seen, and when I looked in my crystal ball, what it tells me is that planned care is going to become a much bigger part of general practice. We know that at the moment 60-something% of people have chronic conditions, and so making sure those people regularly are attending and staying up to date with those services. Also, in our environment, we've seen the rollout of My Medicare. That's going to be expanded further over the next 4 years at least. We know that's all been roadmapped out. And so as those things happen, they have the potential to either be seamless from a GP's perspective or full of bumps. So for example, if that's not managed well, and we've talked about the My Medicare coordinator scorecard that we gave our members last week, but if that role isn't locked down, for example, then that has a lot of downstream impact to the GP, who might be doing a whole swathe of work which ends up being unpaid. Not because anyone intended for it to be unpaid, but for some reason or another, things weren't handled from a My Medicare perspective. So that's just one simple example of how inadequate or poor admin processes can then have a full impact on both patient and doctor, because then it undermines the doctor-patient relationship as well. How about from your end?
I think even just, we were talking about the personalization and the human touch, and it's even understanding the work preferences of the GPs that you're supporting. And so you might see somebody, and they're all different. Somebody might be really comfortable having 2 or 3 people waiting. In fact, some doctors love that. Somebody else might get really anxious if they're running behind. So just really making sure that you're talking to them. Do you need me to communicate to the next few people that you're running late? How are you going with your fluids? Would you like a short break? Here's your cup of tea. You usually like it about 10:30. All the stuff that goes towards having a great shift. And those things should go in both directions. Just to be clear, the GP should also be checking in on the admin team. But really, just the things that show that people care and that they're actually, they've got their back. It can be a pretty difficult job at times. So in general practice, people who aren't GPs won't necessarily know that you might have to break some really terrible news. You're not necessarily aware of that prior to the meeting, that's what's going to happen. And then you've just got to reset and go again and talk to the next person about whatever that might be. And so just recognizing those things in your audience, if you're at reception, you're serving your GPs primarily, and the patients are served on behalf of the GP. And so making sure that you're looking after them well, I think, is going to be really important, that you understand what their needs are, what their best days are like, their worst days are like, and how you get the best out of them, I think is going to be really important. So that's people that are really situationally aware and provide a psychologically safe environment. But I think that the deeper that the reception go with that, then it's going to be very hard for GPs to leave those environments, because you don't really want to enter a system where you're kind of a number, or, you've just got a standardized approach to everybody, because we're not all the same. We all require different things to enjoy a day's work. And so I think that part of it's probably going to be really important, and that sort of personalization at the GP level will be part of that as well.
Yeah, absolutely. Key for retention and reducing cognitive load. So that's from the admin perspective. Then obviously the nursing side, and then there's probably the physical space as well. So if we think of the nursing side, I think as general practice evolves and changes, and some of the roles sort of modify, and GPs are asked to do more complex work, the role of the nurse will become even more important in a general practice. And so along with that, there's going to be the importance for nurses and GPs to work together even more efficiently and effectively than they currently do. I think there's been a growing trend towards some paid nurse services, where patients pay directly for nursing services in a general practice. I think that will continue. And probably expand as time moves on. And I think the patients, they really do enjoy nurses, because nurses offer a different something different to that which the doctor offers. And so I think that historically nurses have been seen as the caring listeners. Maybe they have a bit more time for the patient, people have thought, and then they offer a whole range of services that and skills that doctors don't possess. And so as and I'll give a sneak peek to system, as we see a bit less done in hospitals and a bit more done in community, that means there's going to be an elevation of some of the skills that doctors have to, and services that doctors have to offer. And so as part of that, nurses are going to have to step up and do more from utilizing their skills. But all of that has to be done in a caring manner, which nurses are great at. And so I think that's not going to change. It will still stay the same, but it's going to have to elevate and increase, because I think you can expect that patients will probably in many cases be paying for those services as well as potentially there will be some Medicare funding for those services as well. In what format that comes, whether it's some sort of block funding in addition to what's already there or something else, is hard to know. Any Medicare funding may come with some sort of handcuffs that sort of limit what you can do and how you do it. And so in recent times, we've seen a move towards improved nurse utilization and efficiency. And I think that whilst maintaining the caring aspect, that's going to have to come into it as well. We're going to have to continue to work on efficiency and effectiveness in doing the work because of the resources that may or may not be available to fund that.
Yeah, and I think, as I said, patients like it. We work with a real diversity of practice owners, and some already have private direct-to-nurse immunisation for childhood immunisations, and that kind of makes a lot of sense. That wound care, childhood immunisations, things that nurses are great at. As you said, nurses are the champions of patient advocacy. And so, again, the diversity of approach, I think, makes the clinic stronger overall, and it's a great experience for patients. So it does make sense that there are some things where the patient literally comes in, waits out front of the nurse room or the treatment room, sees the nurse, and then that's it. There's a lot of things where the doctors metaphorically come in to endorse the treatment, where the nurse is probably better at that than the GP. Wound care, childhood vaccinations, I think all of us would agree that nurses do more of that and have more appropriate training in that. And so in those areas, nurses are superior at that work. It's a bit of an artificial construct that the GP has to get involved. So just improving the patient experience by having them go and address that concern and then go home. That's true team-based care. And I think we will see a move towards that, whether it's outside of the system and privately, as we've seen it with some of our members, or the system adjusts to accommodate that. I'm really uncertain why that didn't happen with this current, it seemed like the current changes would incorporate changes for nurses, but actually what the federal government have progressively done is screw nurses in the general practice setting and removed item numbers they could use, and they've paused the support and the funding. They've never indexed that the funding through PNIP and WIP, etc. So the government, what they say and what they've done have been the opposite. I suspect that will probably change at some point, but it's been disappointing responses from the government in terms of lip service versus action on practice nurses in general practice.
Absolutely. And I think the only other thing to consider is the physical space. I think consultation rooms will broadly stay the same. I wonder if reception spaces may change, potentially smaller, potentially with automated notification to patients. So they may not necessarily come and wait. They may just be in the vicinity. A text comes, the doctor will be ready in 4 minutes, and then they come in. A bit like the buzzers for when you order something at a food court or whatever. So I wonder if something like that might change, which would mean the reception area may become more for some of the vulnerable groups who have to, mobility and transport is an issue. So then it might become a place that's more for that group, and then people who have got multi appointments, and so they may actually not be needed to have as big a space. And then so that whilst you'll still need that space, probably the way it's used might change. I think consultation rooms will be pretty similar. Then treatment rooms, I think there'll still be a need for space to do vaccinations and some of the other services, dressings, etc. As to how procedures and some of the more time-intensive services are offered. I think that will depend on the type of practice that's run. If there isn't more funding forthcoming, then bulk billing practices may decide that they become largely consultation spaces and not offer a huge deal by way of more complex services. Not because they can't charge. I think my understanding is at the moment they can, but it's likely there'll be changes that will happen to some of those rules as time goes as to what you can charge for and can't charge for. That I think that's almost guaranteed.
Yeah, and also there's an expectation from the audience they're pre-selecting for that they won't be paying for services. Doctors seem reluctant to embrace the consequences of the decision to universally bulk bill, and I think if you don't embrace it, you're just going to miss the opportunities and get caught up on what you lose. That's that human thing of loss aversion, right? If you like doing procedures, it's probably, unless you're in an environment where you've got a captive audience, i.e. a remote or rural area where you might be able to enforce both, that you bulk bill the routine consultations and you do privately billed procedures. If it's in an environment where there are alternatives, you're often going to see that those people aren't going to be getting that care from that same environment, I think. Sachin, can I ask you about telehealth? What do you think will remain the same and what will change with telehealth in the practice environment?
I think telehealth, volumes, you might see numbers creep up, but in terms of what's dealt with by telehealth versus what's dealt with we're talking in the next decade versus what's dealt with physically in the practice, I'm not sure it's going to change a great deal for the diagnostics and for examination and for proper treatment. Even with wearables and some of the other advances that will be there, I'm not convinced that a clinician will be wanting to take that sort of risk on an ongoing basis. And so I think we're probably at 70% of where telehealth will get to. So there may be like a 40% elevation from where it's at the moment. But otherwise, I still think the bulk of care will continue to be done in the physical setting. And then there may be some modifications as there's more algorithmic driven care for some of the things that are easier,
single disease kind of states.
Yeah, exactly, to manage algorithmically. But generally, I think there's not going to be a huge change. The opportunities for a practice might be that they do, embrace in the physical space, more telehealth space. But then if you're doing telehealth, perhaps you could just do it from home just as effectively, and then you just make better use of the practice footprint as rents increase. So yeah, I think there'll be some mild to moderate increases in telehealth, but again, I don't think you can replace it. Can supplement physical in-person care, but I don't think it can replace it. And there's probably a wishful thinking if we think it can replace it. I think it's more hoping it can replace than actually.
I think a lot of that's supplier-led endorsement rather than led by patients or GPs. Yeah, I think there's that common saying in medicine, more mistakes are made by not looking than not knowing, and it's very difficult to do the looking part when you've got a limited amount of information. So I think the reality is, as you say, probably the vast majority of the movement towards telehealth has been done, and there might be some incremental changes for follow-ups or structured check-ins, but beyond that, it's probably done. And I think the opportunity for people to work from home is a really positive one, because it is literally work from anywhere. It's got to be within Australia, obviously, but there are people that could have 3 days in clinic and then have a day that they consult and 3-day weekend somewhere else. That might be the diversity and the variability that people need to have a good life in general practice. So that's a useful thing. What about if we jump to the system level, Sachin? What do you think will be the same over the next decade?
Yeah, well, general practice, does somewhere between 87% and 92% of patient interactions. I think that's going to continue. And in fact, I think what we're going to see is, and we're seeing step one, which is the non-GPs who are being asked to do GP type work, pharmacy, nursing, nurse practitioners, etc. Those scopes will be expanded, which we're seeing. And so a lot of the simple is being moved to them. And so I think what we can expect is more of the complex will move continue to move from secondary or tertiary care into general practice. And so I think we'll continue to see that movement. And so we'll continue to see these, what's quoted as top of scope, everyone working to top of scope. And
I always think when somebody says that, I always think I could get to work if I was allowed to drive my car at top of scope. I could get to work so much faster. I could ignore all those speed limits, and I've got a drift mode. I would like to get drift mode going on the way to work. I reckon I could be at work in 30% of the time if I could drive at top of scope. I don't think it'd be dangerous because I'd be operating at top of scope. That's exactly what I'm meant to be doing.
exactly, there you go. What could go wrong? So I think we're going to see that general practice continues to do the heavy lifting of the health system and continues to be a fundamental central part of the health system. And we're going to see as hospital care gets more and more expensive and complex, what was once deemed complex is now going to too complex for general practice is deemed is now going to be moved to general practice, much in the way that stuff is being moved from general practice to pharmacy or nursing, etc. And so with that, the question becomes, will there be adequate funding for general practice? Will it be the same as what's done in hospital? Obviously it won't be, because general practice is the most efficient part of the health system. And so general practice will find a way to offer those services at a fraction of what it costs to do it in a hospital. And that's the reality. So I think we're seeing it happening right now, and it will continue to happen. They've already again flagged funds where they're experimenting at the moment with keeping people out of hospital. And so, that will become a bigger part of general practice work. What we've seen in the NHS is the rise of the non-doctor. It hasn't been overwhelmingly successful for the medium to long term. I think most studies that I've seen suggest that it's often even more expensive than having a GP do the work. But the reality is that's happening, and it's going to continue to happen because there's a fashion and a vogue for it around the world.
It actually doesn't matter if it works or not. It's just going to keep happening.
They've chosen their path. They have their beliefs. That most people who make these decisions don't actually properly understand health and general practice. I can say for sure they don't understand, but that's the reality of the situation. And so as that happens, we worry about the demise of general practice. I don't think there's any concern to be worried about the demise of general practice. There's a lot to be annoyed about, don't get me wrong. However, you can see that a lot of these services are going to come into general practice. And so it might be infusions, might be IV antibiotics, it might be certain home care things. They're gonna come into general practice, and there'll be some funding that will come with it. It will start small, and then it will grow. And so I think when you say what is going to stay the same, I think from a system perspective, its change is going to stay the same. And in general practice, what we have to do is continue to do what we've proven ourselves to be really good at, which is to be aware of the changes that are happening, be open to the opportunities that they present, and then design the way we operate and deliver those services so that they can be good for patients, but also done in an effective manner that makes commercial sense. Because without commercial sense, then you're an NFP, and as we all know, NFPs don't always do that well, and so commercial sense has to be at the basis of this. And if it doesn't make commercial sense, then you need to have a fee that makes commercial sense, or it won't happen. And I think in general practice has done pretty well with that so far. And those that are thinking ahead and in the right environments, thinking about how to embrace such change, they'll be ahead of the curve and be able to really take advantage of some of those opportunities. And, we've seen people do that back in the days, for example, with vaccination, with COVID and the height of the pandemic. We had people working with us in Project X who were delivering the same vaccines as were being done in hospital or community health settings with 10 times the number of staff. And they were doing it safely, effectively, and with great satisfaction from the patient. And so we know that when those opportunities come up, it's just about thinking about them differently and doing it in a way that makes commercial sense without compromising the outcomes of what you're delivering.
Yeah, I think general practice is pretty good at MacGyvering a solution, that makes sense. And it being a small business environment, you can't have the luxury of having 10 times as many staff because those things are unsustainable and you just don't have those resources available. So the resource constraint sometimes produces the inventive solution. Sachin, one thing I read recently, and I did some study on this myself, was that the revenue or the investment per patient in general practice in Australia has remained stagnant for a decade now. So that's roughly $450, $460. That hasn't changed over the course of a decade. Do you see that changing? Do you think that the governments in the next decade are going to invest proportionally more into general practice? Or do you think we just have to accept that that's pretty stagnant for the next decade as well?
Yeah, it's an interesting one. I looked at the real, if it was inflation adjusted, and it looks like a 20% reduction in terms of real term reduction in per capita Medicare spending per patient.
I'll run a mini mental and you'll just check where you are and when it is.
So I'll be interested to see what happens if we take lessons from other places. My suspicion is what will happen is that the actual change will be negligible in terms of increases of funding. However, it will be spun as extra funding. So yeah, politics. So we're going to fund GPs this much to do this job, whatever this job is. And at the same time, something will be cut, but they won't mention the cut, just the perceived savings from that cut reinvested. And so they'll talk about the investment. That's what I've seen happen in the UK. And I think we've seen some of that play out here over the last 2 years with some of the changes that have happened. So I don't think we would be wise to expect massive or significant increases per capita in general practice funding. If such funding eventuates, my suspicion is it will come strongly tied to the requirements to make it bulk billed or free. And so you just need to be aware of that. And so, yeah, that would be my suspicion just from what I've seen and read and what the government have said over the next 4 or 5 years. They have said they're going to get to 90% bulk billing. And so what that tells you is anything they add is going to need to probably be bulk billed. Probably.
And so from a planning perspective, if you're a practice owner, then what it means is that you have to have a focus on efficiency and you're really going to need to make sure that you're watching your costs closely in the next decade and looking for ways of potentially saving in other areas of medicine, because what you can't cut back on is the coalface service delivery. You can't cut back on the clinical encounters and servicing the needs of the patients. So you're just going to need to be more mindful of the work you do, and particularly if in an environment where you don't get to choose the income. If you're in a bulk build environment, then obviously that becomes a really, really critical focus. We just can't be lazy about the allocation of the overheads in the business. Is there anything else you think from a practice owner perspective is going to be relevant at a system level for the next decade?
Well, I think as a practice owner, there's been, there was a time where you could just open the doors and build it and they will come and, it'll all be okay type situation, field of dreams. It's not like that now. This is now there are serious commercial pressures and opportunities in general practice. And so I think as an owner or a group of owners, you can't really afford to be complacent or I'll deal with this later or put things off that you may have ignored before. The pressures are just too high on the business side. And so costs is one thing. Leadership is going to require, high quality leadership. The days of saying, people just in the practice do what they want and, we can't make people do things, or we're going to need to elevate our leadership and the way we address that to create.
There's no software for that, Sachin. People always want a tool.
There's no tool. Plenty of tools in leadership, but there aren't tools for leadership.
Absolutely. Any final thoughts on the permanence? So what are the things that we can rely on and what are the areas that we might just need to keep an open mind about? So you think that they might remain as they are, but they could change, and that might be opportunity. I mean, it's easy to think about threats, but it could be some opportunities that open up in the next decade as well. What's on your mind there?
I think what you've got to be thinking about is those fundamentals we talked about when assessing from a patient perspective. You've got to think, how can it improve those 4A's? Whatever you choose. From a GP perspective, I think, how can we enhance or make more efficient and support